Alrighty, so we are the hub team, and we're happy to be part of this community. And I'm going to welcome Dr. Carrie Rubenstein, who is the director of the Swedish Geriatric Fellowship, and she's going to speak to us today about assessing and treating pain in people living with dementia. Thank you so much, Carrie, for joining us today and speaking about this topic.
My pleasure. All right, and thank you for having me. It's always a pleasure to be part of this community. So I'm going to talk today about assessing and treating pain in people living with dementia. I've learned some for this talk because I've given a similar talk on assessing and treating pain in older adults. And there are a lot of principles that span older adults, but there are some specific principles that are unique to people living with dementia. So we'll be focusing on that, reviewing issues unique to people living with dementia when assessing and treating pain. We'll talk about screening tools. We'll talk about what evidence exists and what evidence doesn't exist in terms of assessing and treating. And then I'll leave you with a stepwise approach. And of course, there are always many approaches. And so some of this is from evidence, some of this is from my practice, and I would love to hear what you think in terms of some of the points I bring up. So why should we care about this? We know there are many people living with dementia in the US. We know that by 2050, that number is going to double, and that a common problem associated with aging are painful conditions. And we also know a very consistent number I've seen cited many places in the literature that about 50% of people living with dementia have a painful condition. And this is similar to people who are not living with dementia. And so that's a lot of people that have this problem. And so we also want to think about this problem really specifically, because what we know is not only is this common, but that it's important because there are a lot of bad potential outcomes in terms of harms when care partners, caregivers, and clinicians don't recognize or interpret expressions of pain. We know that this may lead to, and I'll talk about it in future slides, but under-recognized and under-treated, absolutely for sure, pain in people living with dementia. And that the inability to recognize and treat pain consistently leads to a lot of poor outcomes, including behavioral symptoms, including increased caregiver and care partner strain. And we know from our other teachings that those things often go hand in hand, behavioral symptoms and care partner strain and institutionalization. You can put all of those things together. We think about the really important geriatric outcomes of decreased function and quality of life, and untreated pain can lead to worsen function and worsen quality of life. We think about the ever important polypharmacy issue, and this issue is very much connected to the polypharmacy issue. We think that untreated pain can even accelerate the course of dementia, and that's important. And then untreated pain can lead to falls. And so this maps beautifully onto our age-friendly framework of the 5 M's. This is an absolutely what matters most issue, first and foremost, pain in people living with dementia. But as you can see from my from the things we've just talked about, medication, mentation, mobility, and we're going to specifically say nutrition, but absolutely all of these things play a role, and that's why this is so important to talk about. And this is hard, right? This is super hard because symptoms associated with dementia, like diminished language capacity, memory impairment, behavioral symptoms, may lead to difficulties articulating the pain experience, right? And so therefore, our care partners, our clinicians, the direct caregivers may not recognize or interpret expressions of pain correctly. And this can lead to delay in treatment and all of the things we talked about on the last slide. So this is really hard, and it's why it's so important to talk about today, but also to research more, because we don't have a lot of evidence, as you'll see, in terms of how specifically to assess and treat pain in people living with dementia. And then the other thing that I think is super interesting, I read a whole article on this concept of we talk about this a lot here, sort of personhood and strength-based issues in people living with dementia. Well, it's thought that, when the care partners are not noticing the personhood that remains in people's dementia as they progress, they're less likely to consider pain and to think about the pain experience in that person, because that person in their mind may be lacking the personhood that they once had. Which I think is super important. It's another reason why we have to get all of our care teams trained up and aware of these issues. So when we give a talk about pain, we need to just like remind ourselves, like, what is pain anyway and what types of pain? And I won't be talking like very specifically about this, but I just think it's important to recognize and remember, that nociceptive somatic pain is like the arthritis pain that is so common in people as they get older. But the nociceptive visceral pain, like renal colic, for example, and constipation, more common as people get older, right? Neuropathic pain, especially those radiculopathies, more common as people get older. And of course, the longer they live, the higher the risk the chance that they'll develop dementia. And so for all these reasons, and then this nociplastic sort of multifactorial and overlapping pain type. So important just as a background to think about this. And so first, we're going to talk about assessment, and then we're going to talk about treatment. So in terms of assessment, the most important thing about assessing for pain, and specifically assessing for pain in people living with dementia, is that it should be a multi-dimensional approach. You should include as much facets of the pain experience on assessing for different aspects of the pain as possible. So that could include self-reported assessments, and that is recommended if possible. And usually in early and middle stages of the disease, and even some later stages of the disease, this is possible. And when you can get self-reported assessments, you should get them. You should get pain history information. And sometimes when a person can't articulate that, you need to read through the notes. You need to talk to their family. You need to try to understand, what is this pain anyway, and what is the history of it? You need to think about their individual coping psychological attitudes and beliefs about their pain. And again, this may be something you need to like really dig deep into care, the clinicians and the care teams that are caring for the patient, and sometimes often their family. As a clinician, you need to do a really good physical exam. You need to focus on common conditions that are conditions that are common to older adults. And again, you're going to be looking even more carefully at these folks because they may not be able to say, my left knee hurts. You need to look at all of those parts of their body, right, in a more careful way, and understand their type of pain. Informant-based ratings, so these are ratings, and we'll talk a little bit about scales in the upcoming slides of the people that are caring for or spending time with the individual living with dementia. And then you need to be able to observe the pain behaviors over time. And that's really hard when you're busy and you're running, if you're seeing a patient for 5 minutes or 15 minutes or 20 minutes, or if you're lucky, longer. So what does the evidence say about assessment tools? Well, there's a lot of assessment tools, and we're going to review some of them, but there's no one that's sort of better than another. And I think ultimately, the tools, again, that are more multidimensional, and we'll talk about that as we go on, are better. And so it's fine to start with simple assessment tools like a numeric rating scale or a FACES rating scale. And in fact, they can be very helpful, especially monitoring over time. But when we get more detailed in our assessments, then we get more information. And we know about this from all of our assessment tools that we use in geriatrics, but very specifically in people living with dementia. The tools allow us to look for the right things and ask the right questions. And this is because this is so hard, we need to really think about this, using these tools regularly, right? And having a very high index of suspicion. So this is a tool that, I think I want you to sort of take home from this talk if you don't know about it. And it's the PAIN AD. So this is the Pain Assessment and Advanced Dementia Scale. The good things about this tool is that it has a multidimensional component to it. And yet simple to use, requires minimal, if any, training, and takes into account breathing, negative vocalization, facial expression, body language, and consolability. So multiple aspects of this. Each response is rated from 0 to 2, 2 being evidence of more pain or discomfort, and then you get a total score ranging from 0 to 10. Multiple studies have supported the reliability and validity of this measure, and there's a study that looked at the reliability and validity over racial groups, specifically Black and white, and it showed that there was not, it was reliable and valid over those racial groups. So I think that's really important. I have used this tool in the hospital. I've used this tool in the nursing home. It's a great thing to like bring to a nurse that's caring for your patient or a aide that's caring for your patient and review it, because again, sometimes people don't even know to look at facial expressions when we're looking for pain or to look at body language. And this tool helps really educate people about that, which I like. This is a more comprehensive tool. It's the pain assessment checklist for seniors with limited abilities to communicate, and includes 60 items with multiple subscales. And you can see there's a bit of overlap with the pain AD. It just takes longer, and basically it's either present or absent, and then higher number of present things means the more significant the pain. And again, these tools are really good for looking at pain over time. And so some of it is just about who's going to use the tool, educating them, and then using it consistently over time. This, if somebody can self-report, this is a good tool, and this is a tool that we use a lot in the clinic, and this is the PEG-3. So the nice part about the multidimensional aspect of this is that's not just reporting the pain, but it's reporting how their pain impacts their function. And so it's 3 questions. What number best describes your pain on average? What number best describes how during the past week the pain has interfered with your enjoyment of life? And then how does the pain interfere with your general activity? So I think this is a really simple, nice tool. This is available in our version of EPIC at Swedish Providence, and so it's just something good to know. I thought this was interesting. I've never used it before, but there's an electronic pain assessment tool, which is in a point of care app, and it uses facial recognition technology. And the psychometric properties make it suitable for use in people with middle and even later stages of dementia. It has switched names because somebody bought it, I think, but like keep your eye out for this, because this could be a tool that we use for this problem in the future. So when we use these tools, we need to, again, high index of suspicion, right? We may not be told by the individuals we're caring for that are living with dementia that they have pain. So we need to think about screening them regularly for this. And we want to use self-reporting tools like the PEG-3 when possible. We want to train our teams about this. These are like this, I'm kind of saying a lot of the same things over again because I want to emphasize the importance of that. And so shifting from assessment to treatment of pain, I just tried to like collate a few of the interesting findings, I guess, in my literature search about this. And so number 1, widely accepted that people living with dementia are under-recognized and under-treated for pain. It's very, very important to understand that. In specifically nursing home settings, it's been documented that in, for instance, this article, systematic review of hip and pelvic fractures found 50% less pain medication given to people living with dementia versus cognitively intact older adults. Like, I thought that was pretty striking. And there's sort of this very difficult piece, and I would love to hear our hub's thought about this, but like conflicting evidence about the neuropathologic, the neuroimaging, the experimental clinical research surrounding this question of dementia neuropathology and how that relates to pain processing and perception. Because I don't think we really know, but I would love your all thoughts on that. And there's some evidence that suggests people with dementia may require more analgesia, not less, to reach an appropriate level of pain relief. Again, I don't know how much, we just don't know. This is where we need more research. This study, and we'll get to this a little bit later too, but this one study looked at behavioral symptom of agitation in people living with dementia and just treating it with a low dose opioid. And in this tiny study, half of the people improved in 4 weeks. I'm not sure what to make of it, but I thought it was kind of interesting. And that this other study really looked at this concept of a stepwise protocol to assess and treat pain, and it helped, and it led to better outcomes. So I think this may be a place from a system standpoint that we can get some of this kind of research or understanding into practice. So the next set of slides are not very, I'm going to highlight some things in people living with dementia, but it's really about geriatric prescribing principles. And I don't know if we have our pharmacist on board, but I would love you to check in, check me on some of this stuff. But generally speaking, we need to educate the people that we're going to treat for pain, including people living with dementia and their care teams, that the meds are just one of several approaches. Like, it's never going to be meds and nothing else. We're going to need to understand what the beliefs, the attitudes, the goals, and expectations of people when we start prescribing for pain, and an emphasis on improving function, and very specifically trying to have a goal of what we're hoping that they can do from a functional perspective before we start any medications. We want to, and that's going to be some of the shared decision making. And then, like, always, and forever, you know, if things aren't working, we want to make sure that we deprescribe. So this is just a reminder about the changing pharmacokinetics and pharmacodynamics in older people. And I guess we're not going to like dig into this because it's not the topic of the talk, but the really important thing to know and to remember is that older adults are particularly at risk for adverse drug events because of inappropriate dosing of renally eliminated medications. And so higher peak levels, longer duration of action, delayed clearance lead to increased side effects. And then sometimes, very specific to people living with dementia, you keep that medicine around longer, it's going to have more psychoactive effects. Really, really important to keep in mind. Some other general principles, again, we're treating to improve function and quality of life. That is our main goal. And because of that, even though there will be adverse effects due to age-related changes, we should be careful, but we should not limit consideration of medications, including opioid therapy, for instance. Like, we need to be really thoughtful about this. Sometimes they're like, oh, they're 90, like, we can't give them oxycodone. That is simply not true. And it's just really important that we understand there's adverse effects, but we really balance that with the potential of benefit of medication. Always least invasive and most and reliable method, a consistent method. Start low and go slow, forever, always and forever, and again, deprescribe when appropriate. Really important to think about all of the things other than, because of the fact that we know people are sensitive to medications as they get older, even more sensitive to medications when they're living with dementia, we need to try our non-pharmacological treatments first. And this is a really neat summary. This is not very specific to people living with dementia. This is in geriatrics, generally speaking, and thinking about the like potential positive outcomes of all of these non-pharmacological treatments. And we could have a whole talk about CBT and acceptance-based therapy and some of the really interesting things, but understand that we need to consider these things when we're creating a care plan for treating pain. Exercise is number one and will forever be number one. So anytime we can mobilize, we can make people more physically active, this is going to be a really important intervention for people living with pain. There wasn't anything specific I looked to, like, for some of these interventional pain management techniques in people living with dementia, but just keep these in mind because I think probably these are underutilized in people living with dementia, because getting them to getting them to and from multiple visits to consider this. And again, I think some people who seek out these treatments are people who can advocate for what they want and what they need. And so keep these in mind. Topicals are always a great start. Evidence is interesting. So there's really good evidence for diclofenac gel in hand and knee arthritis, and a number needed to treat is about 10. So I think we're underutilizing these very much so in the nursing home and adult family home and geriatric population in general. There is much less systemic absorption, but if you use a ton of diclofenac gel over a long period of time, you can have renal impairment. And so you have to be a little bit thoughtful of that. Topical lidocaine, moderate quality evidence for neuropathic pain, specifically a number needed to treat of 11. And so lidocaine patches are always a good option for individuals, and patches are good for people living with dementia, except sometimes they're maybe more likely to peel them off. I'm going to move a little bit more quickly because I'm getting close to my 20 minutes. But good and bad news about acetaminophen. The good news is like it's really safe, and it's like safe. It's like safe, very safe, generally speaking. I did read something recently about high doses of acetaminophen over time can elevate blood pressure, and that was surprising to me. It was like 5 milligrams of millimeters of mercury. So I thought that was interesting, but like mostly very, very safe, but just not very effective. And thank you, Nancy, I saw your message. And so I don't think it's wrong to use acetaminophen, but we have to understand that the evidence does not support effectiveness in many different situations. And so there's some specific studies that look at people living with dementia. And one of these studies looked at 25 people, a good, I like the old, when there's a mean age of 85 is excellent. And in this case, when they gave acetaminophen over time for chronic pain or for pain, they saw an improved social interaction. So I thought that was interesting. This study found no difference in pain levels in treatment over time with acetaminophen. And so it's safe, but maybe not that effective. And so then next we think about NSAIDs, which are often really effective, right? We all know that from our own life, I think, but like say more effective, but definitely with more risks. And so when we're thinking about NSAIDs in older people, not necessarily people living with dementia, but in older people in general, we need to have an ongoing assessment of risks and benefits. They're going to be very individual. We're going to be thinking about renal effects. We're going to think about GI effects in people who have a history of ulcer, for instance, and we're going to think about cardiac effects because there are some cardiac toxicities of ongoing use of NSAIDs, but generally lower doses over shortest period of time. And I wanted to just put out there some suggested starting doses, in part because you might think, wow, those are like low doses. And in fact, the answer is yes, like we need to start low. We need to not be afraid to escalate doses. But for instance, that like 500 milligram dose of naproxen may not be the right starting dose. We need to start lower and do so because that can limit the toxicity. And then you're not going to give 600 milligrams necessarily 3 times a day in an older person for their pain, but maybe start at 200. And so I think this is super important to keep in mind. A comment on skeletal muscle relaxants: essentially do not use them in people living with dementia. There are a few spasticity and other things that you guys can comment on if you think, but like the amount, the doses of the doses of skeletal muscular relaxants that need to be used to be effective on that problem in a person, older person, and a person living with dementia are not tolerable because of the anticholinergic effects, the sedation, the increased risk of falls and fractures. Like basically just take them out of your kind of like menu of options. That's at least my opinion. And then if we're moving towards opioids, and there are not going to be a long talk about opioids here, but I want to offer that there are some opioids that are better than others in people living with dementia, and especially like in older adults in general. And I would say, if you can, and this is especially the tramadol issue is a little bit controversial, but I would say because of, and I'll have our pharmacist weigh in, the way these drugs are metabolized lead to inconsistent amount of these medications around. Therefore, especially in somebody living with dementia, if we don't know how the metabolism is going to go and the effect of the drug is higher, you're going to have more psychoactive effects in people living with dementia. So stick with oxycodone, morphine, hydromorphone, and hydrocodone, at least in my opinion, and look at those low doses. What I'm hoping for is that Epic, in some places they've done this, but they change the starting dose in people, in older people. So for instance, if you pull up oxycodone in Epic, it's going to say 5 milligrams. But what I'd like it to say in a person who is over 65 is 2.5 milligrams. That doesn't mean you can't give them 5 or 10. It just means it starts there. And I think that's another systems issue we can think about. I'm super interested in buprenorphine. We use Suboxone for opioid use disorder in our clinics, and the sort of other side of that is just the buprenorphine in terms of treating pain. And this is a really new area. And I was really excited about this idea for people living with dementia because it's low dose, it's less psychoactive than other opioids, and it's dosed in a patch once a week, which is great because you have stable effects. However, this study gave me pause. I was unfortunate, and again, a small study, but I was unfortunate to find out that this study looked at people, and again, this is a nursing home setting, so it's a subset, but people, there was an important interaction that was found with people who also were taking antidepressants, and they stopped the bupropion trans patch due to not being able to tolerate it, but specifically led to reduced daytime activity, saying that there was like a somnolence component to it. So more to come on this. Don't forget about adjuvant therapies, but I should say in general, TCA should be off the table. Same reason that skeletal muscle relaxation should be off the table in people living with dementia. And then we need to think about gabapentin and pregabalin. First of all, not a lot of evidence that this helps. But for some people, they do. But look at those low starting doses. And then remember that the gabapentinoids need to be renal dosed. And so what that means is lower doses, because there's an important prescribing cascade that we see with gabapentin, in part because of edema. So gabapentin, higher dose especially, in older people can lead to edema. And there are studies that show increased prescription of furosemide in these cases. And so this really important prescribing cascade. I am almost done. And this is a really important recent article that was published in the Journal of American Geriatric Society that looked at this concept of elder speak. And so this comes back to our personhood kind of a concept, and that this study showed that hospitalized patients with dementia exhibited rejection of care more commonly when they were talked to in this elder speak way, which represents a variety of communication characteristics from simple infantilizing word choices like sweetie or buddy to more complex patterns such as restricting options for people, or using a sing-song voice, for instance. We all do this, but I think we need to be really thoughtful about doing this, in part because this study showed that people with dementia rejected the care and had more, especially from a pain perspective, had more of a worse pain experience when just related to the way they were communicated with. I shouldn't say just, but just as a highlight that this is a super important issue. Okay, so this is just one way to think about pulling all this together. We're going to assess frequently. We're going to try to screen everybody. We're going to have a high index of suspicion. We're going to consider safer options first, multimodal therapy always, balancing the risks and benefits, not ruling out opioids for moderate to severe pain, and continuously reevaluating and addressing goals focused on function, focused on working with teams and families and individuals to have the best outcomes possible. So we must remain with a high index of suspicion for pain in people living with dementia because it's very common. We need to routinely assess. We need to treat in a stepwise fashion. And we need to consider this idea of personhood and training our teams in keeping this really important consideration in mind. So I recently was told about this thing called the Padlet. And I am sharing this as my tool for the day in terms of like education and collecting articles. And so if you want to scan this QR code, you'll see my Padlet, which links to the articles that I referenced for the talk. And I'm done. Thank you so much. Thanks for giving me 8 extra minutes.
Of course. Thank you. Has everybody... Leave it up for just a moment so people can scan the Padlet if they'd like. Fantastic talk, Carrie. So comprehensive. So anybody have any questions?
I see one about Botox.
Yeah, I'm just noticing, yeah.
Yeah, great question. I don't know about Botox specifically in individuals living with dementia, but I do know that like I've had patients who've had really good outcomes with Botox in like post-stroke spasticity. So yeah, and I'm sure that some of our hub can speak more knowledgeably about those treatments as well.
Thank you. Patricia?
Hi, thanks for that great talk. I have a question. Considering the negatives of NSAIDs, but I've recommended to family and friends using high dose acetaminophen combined with moderate dose NSAIDs as a combination treatment for pain, which was first recommended to me by my dentist.
Interesting. I have never seen any study on that, but I would love to be enlightened. And so I don't know. I think the bottom line is that acetaminophen is very safe. And so whether you're gonna neurologically affect different aspects of the pain with the acetaminophen and the NSAID, maybe, but I don't know. There's some evidence on this in pediatrics, like trying to sort of stack NSAIDs and acetaminophen, but I think Trang, I might, defer to her or other team members to comment on that.
Yeah, it might be in a dental journal somewhere. As I said, it was brought up in the hygienist told me it was brought up in one of their conferences and first recommended to me by them.
Cool.
Thank you. Trang, do you want to add anything? Would you like to comment?
It really depends on what kind of pain it is. Usually I ask, I said, have you tried Tylenol before? And then some patients said, no, I never tried before. If it's like arthritis pain, I usually recommend Tylenol, like Carrie said, is safe. So it's always good to try a safer alternative first. And then if they reach the maximum dose for seniors, 3 grams a day, and if it's not working, then we consider the next step. Usually is Tylenol and then Voltaren gel, like Carrie said. So those are the safe options. The next one, then it really depends. We look at the kidney function. We look at the cardiovascular risk. COX-2 is another one that we can use, Celebrex or meloxicam. Those has less GI side effects for Celebrex, but then we got to be careful with people with cardiovascular disease. And then I know that was the pendulum swing before. I was like, no opioids, no opioids. Now we realize that patients who don't have history of alcohol abuse or any kind of diversion, then those patients are safe. I mean, if we give them low dose for acute pain relief, it's very appropriate. I think we have providers who are afraid that patients might go into addiction problems, so they're afraid to prescribe. I think it's an education piece right now as well, because I've been told that it's the opposite. Opioids was not very good for seniors and cause all kinds of problems. So now we have a lot of scares. So providers are nervous about prescribing, but then we know that we hear patients that they are in pain. They tell us they're in pain 10 out of 10 and nothing's working. So I think it's what Carrie said is very, very appropriate that we can try low dose as and monitor. Always anything that we prescribe, we always monitor.
And Brett is asking about methadone. And so methadone is sort of in the bucket in my mind, and Trang, I want to hear yours, of tramadol and codeine, because methadone can accumulate in older people in a way that is more impactful. And so we have few older adults on methadone for persistent pain, but it is it is generally to be avoided in older people and in people living with dementia. Mm-hmm.
Definitely. I think we don't get methadone for people who, not for those who haven't. I think methadone is for those who've been on it for a long time because of their history of pain or other reasons. But for people who haven't, for opioid naive patients, I wouldn't go to methadone first. It's not a first choice. Just keep in mind the Butran patch is because it's used every week, and it's very slow acting. So people complain that they're not getting pain relief just because it takes a long time for it to kick in. And then the gabapentin, surprisingly, in 7 states, gabapentin 600 milligrams is considered a controlled substance. Not in Washington State, but it is a controlled substance. And I also have read something that people can overdose on gabapentin as well. So that's why I think gabapentin 600 milligrams is a controlled substance in 7 states right now.
Any more questions for Carrie?
I'd like to jump in with a question, Carrie. This is Franja. So I love that you're pointing to exercise and non-pharmacologic interventions as the first go-to. How do you get that resource to these people? That's really hard.
Yeah. So there are a number of, specifically when you're thinking about older adult exercise programs, and like for fall reduction, for instance, there are a number of really good evidence-based community exercise programs. And so I'm sure our community connection folks here can speak to those. Persons living with dementia, it's harder, right, to get them out of the house and to get them to some places to participate. There's a set, and I'll link in the chat here. There's a set of good NIA videos, which I really like, and so you can share those with care partners. And I love the idea of like group visits and things like that for exercise. There's a lot of potential creative things, but anything that gets somebody moving. And of course, we know our care partners are. I see Karen's lagging on, but I know our care partners are stressed, right? And time is limited, and sometimes they don't know where to start. So I think it's a really good question.
Yeah, and I'd like to reiterate the piece about the opioid that you guys are talking about. So I know in our community, some of our palliative care outreach providers have expressed frustration in making recommendations for taking care of patients with dementia who clearly have severe pain and have, failed all therapies and feel a low-dose opioid would be very appropriate, and providers are just saying hard no. And it's really sad. So yeah, it's here too.
Thank you. And then there's a comment in the chat from Chris. Do you want to share? Would you like to unmute yourself and speak to that?
Sure. The VA does a program called Geriatric, which is an evidence-based program of fitness for older adults. And we were doing it pre-COVID in person, but transferred to virtual, and can now provide tablets for patients to access. So if you have any veterans that might be interested in that, they can be referred and screened. And it's a cooperation between occupational therapy and MDs that started that program. So it's great. We also have a Move fitness program too for anyone who is also interested in a weight loss component to that. So that is also accessible.
Thank you. Great.
And Carrie, I think this is Kimmy. You've had some questions about, I think atypical dementias and possibilities of, questions about pain. And I think that's a great question. And I don't think there's any good answers, of course, but thinking about, for example, FTD, and in FTD, there maybe preferential changes in the insula and in the thalamus. And so, again, it's hard to know sort of the pain experience, basically. Is it, the primary pain perception is probably intact, but then the person's like integration into the experience and reaction is often quite different. And so advising caregivers on look out for this, like as patients that you're drawing the water in the bath and it's scalding hot. And okay, it's hot, I'm just going to get right in, as opposed to that usual jerk reaction of I'm not going to get in, or just those compulsive behaviors which then sometimes override your reaction to pain. Walking so much that you're getting blisters, the shoes don't fit, but yet still doing it. So I think, sometimes that alteration of you're looking for those reactions and they don't seem to be happening. So perhaps with a condition like FTD that you actually have to do the more primary, almost like looking for a diabetic foot. They don't have diabetes, but look for everything just to make sure there's not something potentially causing pain, because there's not that typical reaction to it. I've had people who, there's eating something, oh, this is hot. This is really hot, and just continuing to eat and, blisters in the mouth. So somebody needs to interfere.
Thank you, Kimmy. And then I see you put in the chat, Carrie, the link to the NIA resources. And then Lynn, thank you. There's information about fitness at home and through Washington Aging and Long-Term Care. Fantastic. All righty. Thank you again, Carrie. Wonderful talk.
Thanks for having me.
And now, thank you, Ty, for bringing this case forward.
Hi, I'm Ty. I am one of the geriatrics fellows that works with Dr. Rubenstein over at Swedish Medical. So thank you for joining me for this case today. Oh, and I do have slides. Awesome. Okay. So my case today is a 80-year-old patient who is female. I've only known this patient for a short period of time. They have a history of Parkinson's disease, Parkinson's dementia, history of chronic audiovisual hallucinations, orthostatic hypotension, and they have chronic bilateral hip pain. And this patient was sent to the hospital due to difficult behaviors at an adult family home that they had just moved into not too long ago. And for this case, it really highlights, what can we do to address certain behaviors that a patient might have, and what kind of ways can we, help support those who are caring for these patients, and what kind of things we should try to avoid so we can provide more geriatric friendly care for our patients with dementia. And next, please. Okay, so the challenging behavior that was presented to us from from the adult family home was that the patient had just arrived to the adult family home, wasn't there very long, and during the nighttime would often get up in the night and wander, oftentimes to other residents' rooms, and it would cause a disturbance in the home. And they would also have some distress at times because of their hallucinations. So some of the hallucinations, maybe they had seen some animals or dogs or bears, sometimes trees, or maybe things that are more distressing, like seeing an accident, like a motor vehicle accident, and they would become very tearful and upset because of some of the things that they've been seeing. They were also often waking up at night, having difficulty sleeping throughout the night, and per the adult family home was having maybe some agitation as well, perhaps during the moments where they were trying to bring her back to the room after having some wandering into other residents' rooms, and to a lesser extent would have conversations with people in the room who weren't actually there, but those were not presenting any distress for the patient. So in response to what had happened in the adult family home, they had removed like plants and photos and the walker out of the room because they were concerned about safety for the patient. Risperidone was prescribed for a one-time dose by a provider that wasn't the PCP. And she also was endorsing and having chronic hip pain, which caused her discomfort when she was up and moving around. Oh yeah, and those were the responses. So the medications that the patient was on, so she's on carbidopa-levodopa for the Parkinson's. She's on fludrocortisone for her orthostatic hypotension. She's on sertraline, which was actually just reduced because they felt maybe the sertraline was a bit more activating for her. The risperidone was a one-time PRN dose, which was discontinued when she was admitted. And then she is also on Seroquel, which was scheduled 25 milligrams TID in the hospital. The evening dose was eventually increased to address the distress and hallucinations the patient was having. During hospitalization, there were no behavioral issues or wandering issues, pretty easily redirectable, but sometimes tearful in the night with like the hallucinations and just being in a new setting. Patient was also on Senna and Miralax and Voltaren gel, and I didn't include this, but Tylenol was scheduled twice a day, 500 milligrams for the hip pain. Okay, exam-wise, the patient, very pleasant, very calm, forgetful. She would say, I know I have memory problems, you just have to remind me. So she was aware of, her memory, and she was aware that, she was actually aware of her surroundings as well, knew that she was at the hospital. She did have some recollection of events that had led up to the hospitalization, but had kind of a patchy history. She's like, oh, I don't remember everything quite well. She did have mass faces and had a little bit of cogwheeling on exam. Of note, she was noticed to have some high blood pressures, so systolics like in the 170s on occasion, particularly when she was lying in bed. But she would alternatively have blood pressures that systolics were in the 80s, oftentimes around the time where she was getting up to do some therapies. We don't have any cognitive screening in our records. And the most recent imaging that she had done was a CT head when she had arrived to the hospital, which just showed generalized age-related cortical atrophic changes. There wasn't any stroke, which is what they were trying to look for, since she had change in behaviors when she had first arrived to the hospital. For her labs, pretty much unremarkable for the most part. So CBC, CMP, they were normal. We don't have records for the A1C or lipids, but thyroid function, B12 were normal. When we don't have other labs, but otherwise her labs were pretty abnormal. There was an infectious workup done too, and that was pretty much normal. So let's see. Oh, okay, so additional information. So risperidone, so that was discontinued when she had arrived at the hospital because it can worsen Parkinson's symptoms because of the dopamine antagonism. So that was discontinued altogether. The Seroquel is more times preferred as an option for treatment for behaviors in Parkinson's disease. One thing that I wanted to bring up that I am not familiar with, but I'm learning more about is this pimavanserin. So this was considered as an outpatient option to manage hallucinations. And just as a background, for those of you who have, maybe not used this in the past or are, new to this medication like me. So it also goes by Nuplazid, if I'm saying that right. It's a second generation atypical antipsychotic for Parkinson's disease hallucinations and delusions. It does have a boxed warning that it does increase mortality for those who are elderly with dementia related to psychosis. So it's not approved for patients who do not have Parkinson's related hallucinations. It's dosed at 24 milligrams a day. Its mechanism of action is mostly unknown, but it is considered to be mediated through a combination of inverse agonist and antagonist activity of certain serotonin receptors. Adverse effects, central nervous system depression, aspiration risk, esophageal dysmobility, falls, orthostatic hypotension, and QT prolongation. Recently in the news, just a few days ago, the FDA had voted that the evidence for pimavanserin and its treatment for Alzheimer's associated disease psychosis, there was not enough evidence to support that. And that's just something recent that came up in the news. So it was not approved for that. So just kind of keep that into consideration. And I'll save all the questions for after, but my wonder is if anyone has had experience using this medication, challenges, successes. I'll go to the questions at the end. Also of note, she's on fludrocortisone, and she was having high blood pressures when she was supine, which is a possible side effect for this medication. She has pretty low PO intake. She doesn't drink a lot of water or fluids throughout the day. So my question to the group will be, what strategies can we implement to address her fluctuating blood pressures? Is it, considering changing the dose of our fludrocortisone? Do we have to promote more PO intake? Or is it a combination of both? Or are there other strategies? Also, for the group, I'm wondering, so she is admitted to the hospital because of behaviors of wandering at her adult family home. Medically, otherwise, she's doing well. She did well in the hospital when we made some medication adjustments. So what kind of strategies can be implemented at the adult family home that are age-friendly and would make a safe environment for the patient? And how can we best support our adult family homes? Because there was a lot of discussion of, does this patient need a higher level of care? But adult family home is already a higher level of care for patients. So what can we do to help support them in these settings? Oh, and then just to bring up goals of care. So just reiterating, addressing wandering behaviors, how to address the distress the patient is having with hallucinations. She every day would say, I want to get up and move around and walk. And she was pretty ambulatory and she wanted to walk and get up and move around. And she, of course, we want her to be in a safe environment. And next. Okay. So getting back to the questions, I just wanted to open up to the group if they have any thoughts about these questions that were brought up for the case, or questions that they might have as well.
Thank you, Ty, for that great presentation. So let's see here. Any questions for Ty? Any questions for her before we try to answer those questions?
And I see a comment about melatonin. Sorry, I didn't include that. Melatonin was just scheduled at a very low dose. I think the dose right now is 1 milligram. So if anyone has any thoughts about dosages, that would be great to hear. I guess we could start with the first one. Anyone have any experience with pimavanserin, this relatively, at least new to me, medication? Any challenges or successes with starting this?
I have used it with a couple of patients. I had a patient who had idiopathic Parkinson's disease for many years and then developed a sort of mixed dementia and was having pretty challenging hallucinations. And this is an anecdote, of course, but since you're asking about if anyone has had experience, in this particular instance, it helped her. The family was under the impression that it helped her, and she seemed to be less distressed. And we tried other approaches, redirecting and support, and in combination with the Nuplazid. It's a process to get the medication, and it's quite costly.
It's always a question of
those are a couple of barriers,
It's to me, it's like always a question of, I'm always questioning of new medications because of our pharmaceutical industry. And so it's like, well, what is the expected benefit of what does the research say is the expected benefit of this medication related to ones that we have? And when you look at those numbers, I think they're usually remarkably small. That doesn't mean that this particular drug might not help, for instance, your patient, Nancy, right?
Right.
But I get stuck there mostly because
Sure.
I'm a big cynic.
Well, no,
Should
This is Mimi. I would also share that we've had some experience with that patients even as they approach end of life and are on hospice. And it's a real challenge for us to get it because of the cost, but we go ahead and do a time limited trial and make sure that the, expectations are well in order before we start the medicine, but we have had some success in using it.
Kimmy, do you want to add anything with?
Yeah,
Wanna
I
share
actually have not prescribed it. I've had people come to me on it and it's been a mix. Some, feel it hasn't been helpful, so we taper off. Yeah, it may be one of those for the right person, at the right price.
Right.
But it's so hard. I mean, we want to have options. You feel like you want, we don't want to shut down the attempt to find new medications regardless of the cost.
Right. We want options in our armamentarium, and at the same time, we need affordable treatments. Thank you. Any thoughts about how to help with regard to her fluctuating blood pressures? Or her, orthostatic hypotension?
Actually, I guess just to write on that, I'd be interested to hear if folks have advice as we head into a heat wave with increasing fluid intake. I feel like it's a constant challenge.
Thank you. Does anyone have any approaches that have been helpful for people living with dementia regarding, managing heat and dehydration and lightheadedness when standing?
Chris here. One of the things that I encourage folks to do is eat a lot of water heavy fruits, watermelon and all kinds of melons, and they can get the additional fluid that way. And also adding flavorings to water. So there's a number of products in the grocery. You can add drops to water. Some people will drink more water if it's colored. Bright colors, and then it has a perception that it has more of a flavor than maybe it even does. But also adding crystal lights and all these other types of flavorings can get people to drink more fluids.
Great. So fruits and vegetables that have a lot of water can be hydrating for sure. And then what about a straw? Have people had experience sometimes with the straw that people will drink?
So can I say something? At Furcrest, where the people have developmental disabilities, straws are plus minus because some of them just can't coordinate as well. And I think their situation is similar to older people with other degenerative problems such as Alzheimer's. And I totally second the thought on using fruits and vegetables and other meals. And then we make up a concoction called a slushy. So it's, and even something from, okay, I don't want to hear about the sugar, but something from 7-Eleven, the slushies, and you can make up your own slushy, or even, especially in the summer, just popsicles.
Thank you. And Carrie, popsicles and ice cream, it's summer after all. Compression, there are newer compression socks that are out there, which are not as uncomfortable. Sometimes people don't like the compression stockings because they can be so constricting. Obviously, that's what they're meant to do. But there are newer kinds that are a little more easy to get on and off, and which I think can help with the pooling of the blood in the legs.
Oh, Chris here again. I was also thinking there's a product that I actually buy at Costco called Liquid IV, which is an electrolyte formula that has a less strong flavor to it than other people who don't like other types of electrolyte formulas. And also I do a lot of freezing of fruit, grapes and melons and things, and that makes them like popsicles. Also freezing yogurt, just putting yogurt right straight into the freezer can get people more intake. And also making popsicles, just pouring fruit juice in ice trays or some other kind of tray and then just eating it that way, or crushing it up in a blender and making a slushy out of it that way. There's also bananas that you can freeze them and make a nice slushy or a smoothie kind of thing too.
Thank you. And then Carrie, thanks for putting that in the chat, the Sockwell link. Right. And if you keep a smoothie rather than juice or fruit juice, then you get the fiber. So if you're grappling with constipation, that can be helpful. Let's see. Any other things that have worked well in the community? I'll stop sharing maybe in a moment, actually. Reconsider thickened liquid diets.
Thank you, everyone. Those are great suggestions.
What about this question of just from the community about like training the adult family home care partners? This is such a big deal. And I don't know, I think some of them get some training on behavioral symptoms and dementia, but I don't think all of them get quality training. And I think this has come up in the Dementia Action Collaborative and other places, but it got me so upset when we heard what they did for this person. They took everything out of her room. It's the opposite of what we're supposed to be doing. And I was very, very angry about it, and made me think about this question of how do we train our community to do the right thing for these people.
Yeah.
Oh, go ahead.
No, please.
Oh, Carrie, I was just going to mention, all adult family homes that accept anybody with dementia have to go through the dementia specialty training. And that's on top of the other fundamentals and caregiving trainings that they have. I will say there has just been such a shortage of staff and the ability to get people through the trainings and transitions that I just think this has just been a super hard, particularly last year or two, for people to have trained staff that are really equipped to handle some of the behavioral strategies, which we all know are difficult. And a lot of people are placed because their family couldn't manage them. So when you think they have a group of people who all have different personalities and person-centered needs, and, the thing that I've worked more in sort of residential, like assisted living type settings. And so, the thing that I would do is to make sure that the adult family home has people who've been through the dementia specialty training. Allison is a trainer for dementia specialty training. She provides that for a company. And so she could tell you how much detail is actually in that curriculum. But when you look at just everything that needs to be covered, even in that 8-hour day, just focusing on wandering, it's just such a small little widget. But for everything. So a lot of it is really on the job. How do you learn about that person? And I will just say the one thing that you could always throw back at them is in solving any behavior issue, it has to do is what is the need underneath that behavior? And to me, wandering has so many different needs to it. They can be trying to get away from something. They can be trying to find something. They can just be, stressed out and have a need to move. They can be bored. And so the trick with any behavior is to sort of step back and think, why are they doing what they are doing? And to me, that means you take the time to walk with them and you stop and try within whatever communication skills the person have to derive some sort of meaning behind that behavior, because all behavior has meaning. Lack of behavior has meaning. All of it is communication, right? And it's usually some need. And when you can get people to grasp that and to take the moment to step back and think about, were they trying to get away? Were they trying to find something? Were they just agitated? Were they, what is that need? You can usually in some kind of conversation come up with, well, we are walking to, where are we going? And find out, where do they think they're going? Are they, is it the getaway mode or is it the find something mode? And then you can respond to the need, because if you don't understand something about that need, it's hard to manage it. So I think providers very often just want to get them back in, and they don't take any moment to stop and say, why are they doing what they're doing? So I would like to we just finished up they're called caregiver tip sheets, and there's a bunch of behavioral tips, and they're designed for families, but I'd like to just put them in the link for you guys to know that they're there. And they're very simple. They were designed by California, and they're done in English and Spanish. They were done at plain speak, like 5th grade level, so they could be translated into Spanish. But I'm just going to send them to you guys to know that they're there. They could be useful for a provider, offer some tips, but they're really designed for family caregivers. But I just want you to know they're there. But the very first one is called the IDEA strategy, and it's similar to something like STAR-C, the IDEA, the DICE strategy. If you've heard of any of those, DICE, IDEA, or STAR-C, they are all based on the same approach of ABCs. Find out what is the behavior, and then detect, why is that behavior happening? What was happening right before? What might be the underlying need? And coming up with different ways to approach it, because there's never just one approach. There could be multiple approaches, and there could be different reasons. So I'm going to stick that in here. And problem solving behaviors is one of the things that I've done a lot of in the years that I've done working with families. So I would be willing to problem solve with people if they want to do that at any point. Just on a one-to-one, what could the possibilities be? But in the meantime, I'll just put this link in there. I don't know if that's helpful or not.
That's tremendously helpful, Lynn. And I think, just as you said, really pausing and what is the unmet need that behavior is expressing. And it was also echoed, thank you, Chris, by your comment about different approaches. Are there issues with, kind of just really interrogating that? What is that unmet need in that moment? What is that behavior or the lack of behavior expressing? And thank you also for sharing that resource. I think that would be helpful for us. And, we can also share broadly to care teams at adult family homes. And as you said, there's staffing shortages, and there's a lot of challenges with retention and so forth, but we can continue to share that information as well. Yeah. Really helpful. Thank you. Anybody else want to, and ideally to train, to improve skills, because people may lack that understanding and training and skills. Anybody have any other, in the last moment, pressing question or comment, something that went really well that we want to end on?
No, I just wanted to add kind of briefly that, one of the things that strikes me about this case is it's still a relatively new adult family home. And that's sort of like wandering into other people's rooms. That's sort of like, of course, she's confused at where she is. And so sort of doing that education with the family members, like there are things that you can do to help your loved one adjust to a new facility. Like expect that things are going to be rough at first, but these are some practical things that you can do. The Family Caregiver Alliance Council put together some kind of a nice paper on how to, talk to families about that. And I feel like given the shortages within, the adult family homes and memory care facilities, like having sort of empowering the family members to be those advocates and teachers and role models can maybe help that go smoothly.
Thanks so much, Karen. Great. And thank you. Please do fill out that survey, which is in the chat. And then our upcoming session in 2 weeks is with Seth Keller, Dr. Seth Keller, who will speak on the decline in adults with intellectual and developmental disability and concerns for dementia. And thank you all, and have a great rest of your day. Thanks for popping that in the chat, Lynn.
Mm-hmm.
Well done, Nancy.
Great case.
Great case. Nancy, may I start by asking a question to Trang? Trang, wondering if you've had any experience using memantine for pain, neuropathic pain. As an NMD antagonist. We use it fairly frequently in hospice as an adjunct, and have seen some really remarkable results with it, which is share that. Low dose starting at 5 milligrams, no more than 20, minimal side effects. When it works pretty dramatically.
Is that pain or pain association with agitation?
No, it's pain. No, yeah, pain. And specifically neuropathic pain. I can think of a couple of patients who had one patient in a sacral plexus infiltration with tumor and very, very complex pain syndrome. And Namenda helped a great deal. Yeah.
And then is a patient on any other pain therapy?
Oh, yes. It's an adjuvant, to opioids and whatever else. Yeah.
Mm-hmm.
But we're starting to add it sooner rather than later now as an adjuvant, just because of the experience we've had. There's a few small studies in the literature, actually going back a number of years, and the results are equivocal, which is unfortunate because it's not expensive and has few side effects.
Great, I will look into that. That would be great.
Nancy, you were shaking your head. Have you used it?
Oh, I was simply going to add that I haven't used it. I mean, more in the context of people with headaches as well.
Mm.
There is.
Yeah, I feel like I've seen the headache clinic say, next we're going to try memantine. Yeah.
Mm-hmm. So if you have somebody who has sort of moderate dementia and headaches, it can be a nice dual use approach. I don't have experience with the complex pain context or.
It's sort of like anecdotally, I feel like in the clinic, we sometimes think about memantine as, it can help calm people as opposed to like donepezil might up people.
Right.
But I wonder if, is there a component, since we're usually thinking about it at moderate stage, is there some sort of pain component that is being treated at that point?
Mm-hmm. That's a great question. Yeah, and it helps with the motor restlessness and all. Yeah,
Yeah.
and NPI. Yeah, maybe it is that it's also working on sort of pain systems.
I have had other people who felt like it made headaches worse. So.
Mm. Right. That's why we call it empiric, right?
A trial.
So
I
you
was
had
so
a few.
glad Lynn. Oh, sorry. I was just gonna.
Sorry.
I was just gonna savor. I was so grateful for Lynn's really important kind of teaching.
Her
and
just off,
sharing.
off the cuff knowledge of all the resources is just amazing.
I was Nancy, you had a few patients who omnipresent.
Mhm.
Did you see like a big improvement or not really?
You know, it's really hard to say, right? But in one case in particular, as I said, she was very, very, very distressed by her psychotic thinking, and it helped. It, according to the family, and then she just had more ease. It seemed so. I mean, it wasn't like, hit it out of the park, but again, it seemed to help in this particular instance a little, maybe enough to bring down her suffering a bit. And other things hadn't really been effective. We tried a number of other approaches.
I don't think we see very often because of the cost, right?
Right.
Yeah, insurance.
I really struggle with that drug, with the direct to consumer advertising. I mean, it's just all over TV.
I did send a text or the message to Ty because the Nuplazid can also cause static hypotension, which this patient already has. So I just we got to be careful about that as well. That's one of the side effects. And the patient already has orthostatic.
I will add that. I'm compiling the list of things that we talked about for recommendations, but I'll add that one in there too.
Yeah, I would also add if she really wants to try that, would do an EKG as well because it can prolong the QT. What's everyone going to do in a hot weather?
Go to Montana.
Enjoy. That sounds great.
I'm also heading to Montana. What part are you going
Are
to?
you?
Yeah.
Oh, actually headed to Red Lodge, and we're going to spend a couple days in Yellowstone.
Nice.
Not going to be the trip I planned. It's going to be the trip I'm taking. Where are you going, Carolyn?
A couple of spots, mostly outside Helena, and then also near more like Deer Lodge area.
We'll be going by there.
I thought I read recently some Yellowstone is closed.
Oh, it was. Yeah, 10
well,
days ago. It just opened 2 days ago.
Oh,
severe
good.
flooding.
Mm-hmm.
Severe flooding. Yeah. Mother Nature at her finest. How she does things.
Fiercely.
Mm-hmm.
Yes. She's, yeah, speaking for all of us today. Carolyn, are you doing is it a race?
No, I'm doing rock trips. I'm digging rocks. Yeah.
Oh.
My race is in
That's
it's in September. So
okay. Where's that one?
That's in Colorado.
Oh, nice. Oh, maybe I missed. I think I came into a conversation where you were kind of talking about it a little. Sounds fun. Is it a long one?
for the race that I'm doing it's a half Ironman. So long enough. Too long, perhaps. We'll see. We'll see how how I feel about halfway through, if I made a terrible decision or not. But
is it at altitude too?
yeah.
Oh boy.
That's what I'm not. I used to have the benefit when I lived in Colorado or New Mexico. I always had the benefit of then coming to like California and doing races, and I always felt like great. And it's the opposite problem. So it's gonna be it's gonna be tough, but it's okay.
Well, good for you.
Yeah, good for you. All righty. Okay, well, I don't have anything else unless anybody has anything they want to savor or kvetch about. We could do it all.
We're good.
Well, here's a reminder to Tristan that this part of the recording certainly gets edited out.
Yeah.
The final. I'm sure you know that, but I'm just kidding.
I assumed it did. I'm just.
It's a safe assumption.
Yeah, Randy was just like, make sure you're there until it's all the way over. So I was like, okay, I'll be here.
I appreciate that. Well, welcome, and we look forward to working with you.
Yes, thank you.
Yeah, thank you.
All right.
All right.
All right.
Okay,
Bye,
take care,
everyone.
everybody.
You.
Bye, everybody.
Have a
Be
great
well.
weekend.
You
Bye.
too. Bye.